So I'm just seeing the number of participants still increasing here. So we'll just give it one more minute before we start. And perhaps we'll get started now. So I'd like to welcome everyone for joining us in this virtual presentation that is actually the first one that combines the efforts of three organizations who everyone is quite familiar with. So first and foremost, I'd like to thank each of those organizations for their participation and support in this combined effort. And those organizations are, of course, OMAC, CBOM, and OMSTOC. And a special thanks to Coralie from OMAC, who has provided all the administrative support to put this event together. I'll also like to thank our speakers in advance for their participation and the education they're going to provide today, and to all of you for attending. So the format for today will, as we have three speakers, we will listen to those speakers in sequence, beginning with Dr. Maureen Savidino, followed by Dr. Alan Soto, and then Dr. Sydney Sue. You have their biographies in front of you already as they were distributed with the materials for this presentation. But I'll just remind everyone that, that we are extremely lucky to have these three experienced speakers that work in areas of occupational medicine that are very relevant to the pandemic that we are experiencing collectively as healthcare providers. And Dr. Maureen Savidino, who will be starting off today, is a physician with special interest in IPAC, and she has worked with Public Health Ontario and the PDAC Infection and Prevention and Control Committee, and as also was co-chair of the OHA OMA Communicable Disease Surveillance Protocols Committee. Dr. Alan Soto is a specialist in emergency and family medicine, and also certified as a fellow of CBOM, and is presently the vice president of the Canadian Board of Occupational Medicine, CBOM. And his experience is also extensive, having been at OPG for many years, as well as TTC, and has the experience derived from his work dating back to actually the SARS epidemic, and then the H1N1 in 2009, having been both with OPG and TTC at those times. And then Dr. Sydney Sue is specialist in occupational medicine, also a certified toxicologist, and as well as an industrial hygienist, and he's a fellow with American Industrial Hygiene Association, and is currently a member of the Bioaerosols Working Group with Canadian Standards Association for respirator selection guidelines. So I will leave the biographies at that, and invite Dr. Savidino to kick things off here for us.
Thanks, Maureen. Thank you. So it's a real pleasure to be able to speak to you today. It's a topic, obviously, you have to have been living under a rock if you weren't really familiar with this. The other thing is that unlike some talks, you actually have to change your slides every day because the numbers change so spectacularly. I'm going to spend a little time going through the epidemiology, a little bit about pathophysiology. As I said, we'll save the questions till the end. And if there are questions that we can't answer, we'll certainly try and make some arrangements to get back to you about them. So I don't have any conflict of interest. And talk a little bit about screening of healthcare workers as well, and testing, healthcare worker risk and return to work. So this was the dashboard, the Johns Hopkins dashboard, which you're probably familiar with from this morning. Shows the hotspots around the world, and you can see on the left-hand side where we're sitting at about 2,181,000, and those are total confirmed cases. I think it's important to remember that confirmed cases are those that have been tested, some just by clinical diagnosis, but mostly have been tested, which is going to be a huge underrepresentation of what the actual numbers of cases are, both in terms of unrecognized early on and those that were there just really isn't testing capacity. So for example, in some of the third world countries. And 147,000 deaths. So this was from this morning, and I had done it yesterday, so just for interest to show that how the cases have changed in terms of numbers of going up by really thousands of deaths and almost 60,000 cases in terms of increase. So about 1 million cases are in the EU, 680,000 in the US, with 34,500 deaths. It's interesting, even if you're looking at deaths, it makes a difference in terms of how they're counted. So for example, in Alabama, if you only have one lung involved, but you have a positive COVID and you died in hospital, you didn't die of COVID, you died with COVID. So there's, I think that's the other caveat when we're actually looking at deaths, depending on who's counting them and how they're being signified. Many deaths also in the UK, for example, if you died at home, you did not die of COVID. So again, just like there's underrepresentation in terms of numbers of cases, there's going to be probably a pretty gross underrepresentation in terms of numbers of deaths. So we now are at over 30,000 cases in Canada with 1,200 deaths, and Quebec has about half of those cases. This is just a snapshot from this morning. This is one of the CBC interactive events that you can look at, looking at how they are across the country, and you can see that the majority of cases are in Ontario and in Quebec. This is a curve. It's kind of a fun curve because you can plug in which provinces that you wish to. So these are the daily number of new cases in Canada, and it's BC that's along the bottom of the curve. Ontario is the dashed blue line, and then Quebec is the dotted red line, and then the top line is the cumulative number of cases. So you can see that BC has done a wonderful job of flattening the curve, as they say. So expressions that you probably will be indelibly put into your brain, flattening the curve and Zoom and things that we never really wanted to know anything about. But anyway, they do seem to have been doing a good job with that. Ontario is making gains, but we are still having significant numbers of additional cases on a daily basis, somewhere in the 500 range. Quebec has begun to flatten its curve. One of the interesting things is that although we look at the numbers of cases, they are not all the same. So depending on where you are, so if you're in a larger city, so if you're in New York City, so if you've got a high density of population, you've got many more cases. If you have a number of long-term care homes, then what's happening is we're finding that there are epidemics then. So there are hotspots. So if you could look at a state or a province where in fact the cases may not be that many, but if you actually start hunting, then you're going to find them in those long-term care homes, group homes, other congregate settings. So those seem to be at the highest risk. And unfortunately also with very vulnerable populations at the highest risk for a very poor outcome as well. So many of those wouldn't even actually get into the hospital. They would go on to sort of palliative because there really wouldn't be any value to the person, to the family, to the system in terms of putting them on a ventilator, because it's pretty much a guarantee that they weren't going to come out. And as we know with visitation and the way it is now, it's a very sad situation. So unless you've got an iPad to say goodbye to granny, then it's very difficult, whether it's in a long-term care home or in a hospital setting, you're just not going to be able to get in there. So looking at the different ways of doing things, and I think that Sweden may, in a year, wish it had done things quite differently. So there are those that sort of march along to different drummers, and they're, for some unknown reason, their public health folks have basically saying that it's fine to continue life as usual, just, do wash your hands, please. But if you look at the number of cases, they are really increasing, and somewhat as in the way that the UK initially felt that they just wanted to go for herd immunity and that it didn't really matter. That you can see that once the numbers go up, then so do your deaths, and the death toll then can be significantly increased, as it was in terms of Sweden per case per million over Denmark and Finland, which is significantly lower. So Canadian predictions then, our Prime Minister, we would see him every day with his little sort of frosted breath or smiling moistly, as the kids would say, and talked in front of his home about what was going to be looking like for Canada. And so they're predicting that by the 16th of April that we would have between 500 and 700 people would have died with COVID, and we're actually a little higher than that in terms of a death count of over 1,000. And then looking at, but it is very difficult in terms of modeling, and I understand the challenges because depending on whether or not you have the physical distancing, school closures, at what point you do those things, your public health measures, it's going to make a difference. And it's also, you can put them into place, but it doesn't necessarily mean that people are going to follow them. It does appear that in Canada, we're doing a relatively decent job of that, and that we still have, with our acute care, then what we have been able to do is we still have ventilated capacity. So even in areas where there's a significant number of ventilated cases in Southern Ontario, for example, and in Quebec, then we're still doing reasonably well in terms of capacity. So what is COVID-19? Well, it's the SARS-CoV-2 virus. It's an enveloped RNA virus. It's actually a relatively easy virus to kill. So the usual things that you would do around having a hospital-grade disinfectant, for example, if you're cleaning surfaces, it's very effective. All of these coronaviruses have their origins in bats. They have probably some intermediaries, such as the pangolin, which is a very weird-looking rare species that is apparently also a delicacy that was in the wet markets in Wuhan. Camels for MERS-CoV, and the civet cat for SARS-1 likely. So interestingly, SARS-1 was so toxic to the host that it no longer exists. And if we look also for MERS-CoV, there are, it's primarily Kingdom of Saudi Arabia where there will still be cases, and it has a high death rate, about 50%, and about 30% of healthcare workers do become infected. There was one large outbreak in South Korea, but otherwise it's been pretty quiet. This SARS-CoV-2 is a very different kettle of fish, highly contagious, and we're learning more about it as we go along. And there's a real wide range of symptoms. So we have folks who can be asymptomatic. There is probably good evidence of asymptomatic transmission, certainly very good evidence of pre-symptomatic transmission, and people who hardly become sick at all, and others who, as we know, end up on ventilators and will die with those other risk factors that they would have, age being probably the biggest one. So this is just a schematic of the sort of RNA virus and all of the magic that it has, very complicated. The receptors, so it is a respiratory virus, and it has the ACE2 receptors. So those are primarily in the respiratory system. So they're in the nasal pharynx, they're in through to the lungs, and as well there has been evidence that they are in the gut as well. And we do know that there have been some cases that present, particularly in children, but also in the elderly, in terms of atypical symptoms, which include nausea, vomiting, and diarrhea. So just showing you how it replicates and the different pathways and how the viruses then are released. So routes of transmission, there's a lot of concern, and I'm sure that you would have, being in the healthcare field, any of you would be very familiar with the big debate between the use of N95 respirators and surgical masks, and concern about this being an airborne disease. There is really no evidence that it is, and certainly World Health Organization as well, summarizing over 75,000 cases, but there has not been any evidence. What has been said is that there is the theoretical risk that with an aerosol generating medical procedure, so such as if you're doing endotracheal intubation, extubation, if you were going to be doing bronchoscopy, there are certain things that could artificially manipulate the aerosols and make them opportunistic, and that they could be seen to be airborne, but that really hasn't really played out to be the case. There's also, although there's lots of evidence in terms of being able to recover it from surfaces, and some interesting studies done where they've used a Goldberg drum and in experimental settings, and they can have on various surfaces living from hours to days. So copper up to 7 hours, cardboard about 24 hours, plastic and glass a bit longer than that. Those are, you have to remember those are artificially, it's sort of doing it through a high expellation with a drum, high force. So it's not the usual things that we would see in terms of aerosols. But it does definitely show that it can exist on surfaces for a period of time. But as I said, with just good, proper cleaning materials, high touch surfaces, you're going to have that looked after. It has been detected in stool and blood, but the role of that transmission is really unknown at this time. There have been about a half a dozen case reports in terms of infection through conjunctiva. And so far, of all the evidence, there's no conclusive evidence that there's any vertical transmission, so meaning from mom to baby. And there has been no recovery of virus in breast milk, for example, or amniotic fluid. So looking at incubation, it ranges from about 1.2 to 14 days. So it can have a fairly short period up to a long period. The median period is sitting at about 5 days. But of interest, there's something called a serial interval, and that's the period of time from onset of symptoms in one case to a symptom onset in the case that they infect. And that is 3.9 to 4.6 days, which is shorter than the period, the median period for incubation. So that tells you then about that pre-symptomatic transmission. And if we look at the outbreaks that we've had in healthcare, they typically at this time seem to really be among healthcare workers. And often they've been pretty good about their hand hygiene and their PPE during the day, and then they sit down and have dinner together. So, and we don't know exactly how long you have to be, but it is an aerosol transmission close to close, and within minutes, it's that contagious that in fact you can become infected. The lower respiratory tract symptoms, you may have an NPS swab, which is the PCR testing, which is the gold standard, could be negative initially, and so it would be important then to try to get a lower tract specimen sputum if possible. And what we're finding is in terms of clearing people to work, so the gold standard for clearance has been that you're going to have 2 negative swabs at least 24 hours apart, but we're finding that you can have viral particles, not necessarily live virus, but particles that can still be there up to about 3 weeks out. So there is also a non-test option where if you're looking to return people to work if they've been well, that at a 14-day period, if they're well, you can probably safely return them to work as well. What's also unknown is what immunity is. So we're making assumptions that once you're infected, you've got antibodies and you're immune, but it's too early in the day to say whether this is something that's going to end up being seasonal. We know we have 3 or 4 other coronaviruses that are seasonal coronaviruses. The antibody testing is very much in its infancy, and as with some of the original disastrous CDC testing that they did, they spent millions on these antibody kits that haven't been worth their weight, so I think early days for that. And there's some evidence coming out of South Korea about 191 cases, which may be a possible reactivation of infection. So that's uncertain, but something just to keep an eye on at this time. So if we look at risk factors for those, so who should stay at work, who shouldn't, who should be looking after COVID patients or not. So the SOGC, which is our Society of Obstetrics and Gynecology, has come out. They came out with 2 reports. The first was silent on work. The second was pretty clear that there isn't any evidence of vertical transmission. Of course, it's a new disease. We don't know everything about it. But there hasn't, as long as you're wearing correct PPE, unlike the society in Scotland, which said that anyone after 28 weeks of pregnancy should not be doing any clinical care, they haven't said that. They've said that you can base it on what works in the workplace and leave it up to the organization. What we do know is that those who are going to have greater complications, age is probably the biggest thing. So over 85, you've got about at least a 15% death rate, if not higher. Over 65, you're looking at somewhere around about 7%, over 70, about 10%. And that if you have comorbidities such as hypertension, cardiac disease, or diabetes, those all increase. What's also interesting is it doesn't seem to make that much difference whether or not you've got control. So if you've got, if you're on oral hypoglycemics and you've got good sugar control, if your blood pressure, you've been on a medication and you've got reasonable control, does not seem to make that much difference in terms of your outcome actually. So it's the comorbidity itself that is that seems to be counting. But again, it's early days and we'll have to see what that looks like as more evidence presents itself. So just looking at healthcare workers infected then. So World Health Organization did a big study, and there were 22,000 cases among healthcare workers of 57 countries that had reported. In China, their numbers are probably on the low side. So this is going a little bit earlier days back into February at this stage, but looking at 44,000 confirmed cases, looking at, those were cases of disease, and they were saying 3.8% among healthcare workers. Again, difficult to say, and some of the evidence coming out of China may be a bit suspect, and the more that we're looking, that also around the 6 days that we didn't hear about people that could have made a difference, and that they again may have sort of underreported some of their cases as well. Italy, if we look at that, which is probably a more accurate reflection, is looking at about 11% of healthcare workers being infected. And they can be infected. I mean, the thing to remember is that they can be infected by patients in the workplace, but they can also be infected by other healthcare workers in the workplace or infected by community members. So if we look at risk factors, late recognition or suspicion of disease, and that's one of the things we're finding more and more, is it's not the typical high fever, cough, shortness of breath. You don't have to have those things to be able to have the disease and to be able to transmit it. Working in a high-risk department, so if you're on a COVID unit, for example, then those healthcare workers do have a higher number of cases of infection. Longer duty hours, which is something because it's difficult to staff up, and people are just run off their feet, and people are either off because they're sick or they're off because they need to self-isolate, and so then that's had an impact on the workforce. Also lack of, or as we know, or improper use of PPE, and also inadequate or insufficient training. And just a couple of references there as well. So recently, then April 14th, this was in the MMWR. So looking at in the US then, if we're looking at close to 10,000 cases around healthcare workers, median age was about 42, majority female, which reflects actually a healthcare workforce. And of that, about just over half were a healthcare exposure only, just over a quarter a household exposure only, and about 13% were community exposure only, and then some did have multiple exposures. And of that group, then 8 to 10% were hospitalized, 2 to 5% were admitted to ICU, and about 27 or 0.6 or so had actually died, unfortunately. And of the healthcare worker patients, so this is a good thing to realize, I think, if you're looking at the retired healthcare force that's being asked to return to work, you might think twice about it, because 6% were over 65, and 10% of the deaths actually occurred in that group. So I think you have to be really careful in terms of, if you're bringing people back to work, get them on the phones and doing different things. You really don't want to have them front facing, particularly if they're over 70 years of age. Also interesting, of the deaths, it really does look like it wasn't as obvious in the Chinese data, but worldwide data, that there does seem to be a significant preponderance of men dying over women with similar risk factors. But just in terms of active screening then for signs and symptoms, they've brought the fever down to 37.8. Often they won't even mount much over 37.3, and we know if we're looking at fever in the elderly as a screen, it's not going to be very helpful because they often are very low. They often won't even get much over 36. Anosmia is an interesting sign. We had 4 cases last weekend. The only sign that they had, or symptom rather, was anosmia, and they were positive. So they've now looked to really broaden the symptoms, and if you have a single one of these secondary symptoms, then you should really be considering getting tested, especially in the healthcare setting when you're looking after vulnerable patients. So sneezing, nasal congestion, runny nose, and just as we're entering, of course, into spring season, it's going to be kind of difficult to sort that out. Some throat symptoms, including hoarse voice, difficulty swallowing, and more recently then some of these GI symptoms that I've mentioned that have been added to the screen, and unexplained fatigue or general malaise. And it is surprising that just single things like a headache or a runny nose, we have definitely had cases that have ended up being positive as a result. So as I
Maureen,
mentioned,
we have some questions coming in. I'm going to leave them till the end, but I just wanted to reassure our audience that we will be addressing them at the end. And I also want to be conscious of time, that we leave enough time for Alan and Sarah.
Sure. And I'm just about done. So for testing, PCR testing then for nasal NPS swab, first swab sensitivity is often just about 50 to 90%. It is very specific. And you'll hear probably a lot about this Spartan cube, but it hasn't actually been, although it's got Health Canada approval, it hasn't really been tested on humans. So I think we're going to have to wait and see what that looks like. I will leave the exposure case and contact management because there may be some questions around that. And then just looking at, I mean, as we know, there aren't any vaccinations at this time, but there are 70 under evaluation with 3 human trials ongoing, and a number of drugs, which I'm sure you would have heard lots about in terms of hydroxychloroquine, for example. But these are randomized controlled trials that have been approved in Canada. So I'll stop there and thank you. And I'm sorry, I'm a bit over time.
Thanks very much, Maureen. That was a fantastic summary. And many of the questions that are coming in are around the accommodation piece. So we will address those a bit later on.
Sure thing.
Alan, I'll pass things over to you.
Thank you so much. I'm going to just load up my talk. Let's see here.
You need, we could maybe take a question while you get things loaded up.
Got it. I got it.
So the first question was around those comorbidities that you mentioned, and noticing on your slide that it had both work restrictions also on that slide. So has there been, what are people doing about things like very prevalent conditions like hypertension and diabetes? Is that translating into work restrictions in some scenarios?
In some scenarios, I think it's a combination of looking at with age and looking also with if there are other things in terms of immunocompromise. But we have tried to accommodate with not looking after patients on the COVID unit, for example. And the other thing that we do is we have a very, very low bar for testing. So the active screening every day when people come into work, their temperature is checked, and if they answer yes to any single one of those symptoms, then they get tested.
Excellent. Okay, Alan?
I'm ready to go.
All right, excellent. You can go ahead.
All right, thank you so much, everyone. And it's great to be here with such an illustrious board, and I want to thank everyone again. So I'm just trying to get the speaker view out of the way here. There. Oh. There. Okay. So first and foremost, I'm not sure, Coralie, if you can help me here. Just why am I seeing all the people on my screen?
You have to share your screen with your PowerPoint.
Okay. One second, share. Okay, got it. All right, back to normal. Thank you again, everyone. So yeah, this has been in the making for at least 10, 11 years since the last epidemic, and I'm just going to review some of the ongoing data. If I can get my first slide, here we go. So the CDC came out with this pandemic severity, and if you look at the it's similar. If you look at the categories, it's similar to a hurricane. Category 5 being the worst, which is the Spanish flu, and then you have the other pandemics that we had throughout the years. And the category 1 to 2 is the H1N1 2009 pandemic that occurred, and that killed approximately 15,000 U.S. individuals. But that's only U.S. death, And the primary driver here, the point I'm making, is the case fatality ratio on the left-hand side. So if you look at that, that's how you rate pandemics. And that's what we're looking at right now, is probably between a category, category 2 to 3 pandemic for the present COVID. But this is over a 12-month period, so we're not done yet. So I found this picture about the 1918 pandemic, and here, this is no different. There are police in Seattle wearing masks, going around looking for people that are not maintaining social distancing and trying to make sure their people are staying indoor and public safety. And my next picture is social distancing failure. Philadelphia ignored warnings to not have a war parade with World War I soldiers who had Spanish flu at the time. 200,000 people crammed in. And as you can see, Philadelphia is the solid line, and St. Louis, which is similar size, had no parade. And 3 days later, every bed in Philadelphia's 31 hospitals were filled with Spanish flu fatalities and sick. And by the end of the week, 4,500 people were dead. And this is a huge social distancing. This is the reason they want to flatten the curve. So avoiding social distancing, that's exactly what happened. So that's front and center. So having lived through SARS, being in the epicenter in Toronto, I can tell you that all of us have suffered the consequences, namely that we have to be prepared and prepare for pandemics. OPG, and we had to keep the lights on, and we created a SARS task force, and we knew that we had to liaison with our public health partners and emergency operations centers, because without them, we could be inadvertently quarantined and key staff would be inadvertently sent home. The communication part, and you'll hear later on, was critical to all employees and certainly through the executive and stakeholders. So we had to keep essential staff informed. I would send out communications almost on a daily basis, sometimes twice a day as the situation changed. And contingency planning for essential staff and limiting travel was key. We enhanced our hygiene of essential workplaces. We got PPEs and sanitized everything, and we limited public gatherings, social distancing, and we had self-screening questionnaires at every critical entry point. The 2009 pandemic, we're a little more prepared, and I have my pandemic binder here in case anybody's interested. It's from OPG, it's April 2009. It was a labor of love at the time, and we dealt with all kinds of issues, including workplace absenteeism, educating workers. We did a pandemic 101, pandemic for dummies. We screened at entry points, we enhanced cleaning, and by this time we already knew to have an adequate stockpile, stockpile of PPEs, but also antivirals at the time, because antivirals were the only way to fight a new influenza virus, which is what H1N1 was. And we had the largest stockpile of any company at the time to deal with Tamiflu prophylaxis to make sure our critical workers were able to keep the lights on. So that was a huge advent that we don't have for COVID, right? People always ask, well, why is COVID so different? Why didn't we socially distance for H1N1 and SARS, et cetera? Well, we didn't stay home because we had other measures. We knew how to make influenza vaccines, albeit new vaccines. We had Tamiflu and Relenza, albeit in limited supply, but we still had ammunition. We have no ammunition against COVID, and we know COVID spreads much more quickly, and is much more virulent. So we have to do our best. The mitigation options available for pandemics are NPI and PI. The ones we're doing right now for COVID, because there's no vaccine and no antivirals, are NPI, non-pharmaceutical interventions. And those are huge because if we, as Maureen said, social distance, flatten the curve, no public gatherings, stay away 2 meters, barrier precautions, mask, hand hygiene, all of those combined with vaccine and antivirals fight a pandemic. However, we have two key ingredients that we don't have in our armamentarium to fight this COVID, and it's terribly distasteful to stay home for months at a time. And as I'm sure all of you have pandemic fatigue right now. So pandemic planning assumptions. You have to think of what Ontario Pandemic Plan had put in their planning assumptions. And we know that there's going to be at least 2 waves, maybe 3, lasting each about 8 weeks, peaking at 3 to 4 weeks. And I don't think we're at the peak yet, perhaps soon, the end of this week, the beginning of next week. And there's going to be at least 1 to 2 waves, maybe 3 to 9 months apart. So we will see it again, and maybe stronger. The attack rates are going to be about 35%. And absenteeism scenarios may be mild, medium, severe, and impacts are going to be critical to workplaces once we get going. Absenteeism rate, we're going to be up to 40% for peak wave. We know that like we're doing now, there's going to be sick individuals caring for the sick, socially distanced individuals, school closures, worried well, vulnerable populations, and little lead time. So, and there's no vaccine prophylaxis or limited antivirals right now. And there's some new antivirals right now. As of this morning, I'm just going to mention it. It is called Remdesivir, and I have no conflict of interest. Trust me. I wish I could buy stock. It's made by Gilead Science, but it is shown that 68% of the people that were given this drug were able to get off a vent, and oxygenation was back to normal. So that's a huge finding, and I think that is our next ace in the hole until we can get a vaccine. Now, why is TTC so important, caring about pandemic planning? Well, we carry 1.7 million people every day. It's an essential service to the city. We know that the day-to-day work is going to be disrupted, high absenteeism, not only because we know that over a 12-month period, 35% of the workers are going to get pandemic illness. And we know that we need qualified staff. Not everybody can drive a bus. Not everybody can work or fix a bus or a streetcar or a subway. And those are huge, learning curves. So you can't just take a manager and put them on and drive a bus or a subway. And we're part of the 9 critical infrastructure groups of the city of Toronto, and along with electricity, water. And we know that pandemic planning is now regarded as a corporate best practice. Now, I want to shift a little bit about the TTC's main goals. We talk about health and safety, and protecting health and safety of our employees is huge. But there's a new paradigm shift that I've spoken to the CEOs of many companies, and I keep on saying, you can't truly be talking about safety at work without being first healthy. And that's really important. We know all about taking every reasonable step for providing a safe workplace. But as occupational physicians, we have to think about not only the safety of individuals, but also the health of individuals, because the health of individual workers translates into a safe workplace. I'm just going to move a little quickly. I'm going to talk to you about the 10 commandments of pandemic planning and what we've learned over the numerous years that we've drilled and planned for pandemics. And I can tell you that if you take out your playbook now and you have these 10 protocols, you will survive a pandemic and do it with great efficiency. And you have to have all of the 10. And depending on your organization, so this is not limited to electricity or transportation. This is for any organization. You need an emergency response organization or a pandemic task force. That needs to be set up right away. And you need to drill every 6 to 12 months. And those are really important because you need to have an emergency operations center that can handle all the daily, day-to-day changes. As we know, this is an evolving from, in the morning it's one thing, and then in the afternoon it's a different thing. You need to monitor surveillance. You need to keep on top of it. You need OcDocs and Health nurses to monitor what's going on in the world health situation, the CDC, emerging threats. You need internal pandemic disease screening protocols and monitoring to make sure that people that are coming into workplace you're screening for illness, as Maureen said. You need a communication strategy. This is the single most important aspect of pandemic planning that I can mention. And it's so obvious that many people forget to do it. You need to communicate with all your employees, contractors, and it's got to be led and endorsed by a leading executive in your company. You need to communicate with your unions, your public sector, your government, your media. You need emails, you need town halls. I remember at the beginning of this COVID crisis, I filmed a video for a company about, sending it all over the world about COVID and how it's a 10-minute video, but you need to communicate as best as you can. You need policies on masks, antivirals, vaccine when they're available, and just-in-time information. That's critical. Health protocols to reduce the spread in the workplace. You need infection control guidelines adopted from public health, and identifying vulnerable workers like we did at my company. We advised patients who had lung disease, heart disease, chronic kidney disease, and immune system problems over 65, if you have a serious disease, that they may get very ill and possibly have repercussions. That was addressed by saying, if you have those conditions, then you may not want to be in the public-facing jobs, or staying at home. Self-screening forms for critical sites, those are key. Review of close contacts. You need HR protocols. How are we going to pay our people? How are we going to pay people who are sick? How are we going to pay people that are self-isolated? They're not technically sick. They're told to be self-isolating. How about not asking for doctor's notes, not validating medical certificates? Those are all critical things that you need to think about before. You need to think about how you're going to address your first work refusals. If you don't give a mask to an employee or proper PPE, how are you going to address the work refusal in the Ministry of Labor? How are you going to apply business continuity planning for essential mission critical staff in each facility, in each job function? You need to, for facilities, number 6, you need to address enhanced cleaning protocols. And we know that for common touch points, and what detergents are you going to use? Hand sanitizers, gloves, and PPEs. Supply chain, just in time. You need to have adequate supply. We all know you can't get a mask, even on Amazon right now. IT, working from home. Do you have the bandwidth to be able to have 3,000 people work from home? Those are all critical things for social distancing. IT security, make sure nobody's Zoom bombing, as they call it. Now we call security for, you need a security strategy for certain supplies, detergents, hand sanitizers. I was reading an article in Spain. Somebody broke into a warehouse of a hospital and stole all their masks. I mean, those are things that we need to think about ahead of time. Vaccines and antivirals. If I had $1 for every time I talked about Tamiflu or Relenza during the 2009 pandemic, I would be rich. Now there is no vaccine, there is no antiviral. So you need to consider that for most pandemics that are influenza related, the only thing is an antiviral that is sensitive to that organism.
Alan, I wonder if we should maybe just say a few further words and then pass things over to Sydney. I'm just conscious of time, and I want to have time to get to the questions.
Okay, I'm just going to move on to, you could just a sample of a company. If you look at company X and the response stages, and you look at peak waves during the pandemic, you can actually model what your absenteeism is going to look like if you assume a 30 to 35% attack rate. And then you have to integrate pandemic planning with your emergency management. You know that a business impact analysis, business continuity, you need protocols for mitigation and control, preparedness. You need to use your 10 protocols, the 10 commandments, and then what your continuity of operation plans, otherwise called COOPs, and then eventually recovery. And hopefully we will recover from this. And then this is what it looks like in a horizontal form. And I've given you some other charts about typical response actions for essential workers: monitor, communicate, control infections, support employees, and maintain essential operations. And then you can put it in a grid, just like I did. And then you can apply the case fatalities depending on what type of pandemic we're going to have, and assume a 20% absenteeism for a week, maybe 2 weeks. And then I just want to finish off with social distancing. Do not kiss your loved one, as this one is showing you. Anyways, thank you so much for your time. I'm sorry I went overboard. Sorry, Sydney.
That's great. Thank you so much, Alan. And there have been a number of requests for whether the slides and the recording will be available. I've indicated that the recording will be available, and maybe given the amazing amount of information that has been contained in all the slide decks, perhaps we can also share those in PDF format. But I'll leave that up to the speakers.
Yeah, happy to do so.
Great, thanks, Maureen. So Sydney, I'll pass things over to you, and then we can get to the questions. Thanks very much.
Alan, you need to stop sharing your screen so I can come on.
Sorry. Okay. There you go.
Okay. Okay. Well, thank you, everybody. I'm going to first do the disclaimer. Yep, there's no conflict of interest. I get no financial gain. And as you know, the opinion and recommendations are based on the current knowledge. This PowerPoint now, I prepared this around 24 hours at a time, is now out of date. Also, because I'm involved with many other organizations, the opinion recommendations are strictly of mine and not associated with OMAG, the University, Office of Chief Coroner, CSA, and any other. That's all my opinion. And the learning objective, you know, and when you're looking at an infection and any occupational hazard, and we have the hierarchy of protection, and then I want to spend some time on the personal protective equipment selection and care, because I think most of the time that we are hearing is people have some concerns that I don't have enough of this type of personal protective equipment. Is it good enough for me? Is that the right personal protective equipment? Is that the right mask? And I've got asked a lot of those questions. Well, and anybody who is interested in occupational health, and there's 5 hierarchy of protection. And then I'm gonna deviate from the norm and add one extra one. The first one is elimination. If you can eliminate whatever hazard that is, then you don't have to worry about it. And if you cannot eliminate it, and then you can substitute it, but that's not feasible in the COVID situation. Engineering control is, yes, we do have engineering control, and I was in the hospital yesterday, and I was being screened, and this physical barrier, the plexiglass in front of me, and even I go to a grocery store, they have plexiglass between me and the cashier. Local ventilation, general ventilation is when you're doing some aerosol generating procedures or in a hospital operating room, and then you have general ventilation. Administrative control is now how can you use administrating skill to stop the infection from going from the person who is infected to your staff. And patient and staff screening is part of administrative control. Cohorting patient and staff in a specific unit, so a situation it will be in one particular area and not spreading to another area, limiting the number of potential exposure. That means if you don't need to do that particular procedure, you don't want to do them. You don't want to do them, and also limiting a number of visitors. And now most hospital and nursing home now will not allow any visitors. And then I added work practice, personal hygiene, and education. And that's part of hierarchy of protection. And sometimes that, yeah, we try to provide everybody with control and everything else, but sometimes we have to look at how the workers protect himself or herself. And work practice is important. how you do your work, and personal hygiene is important. And the most important one is education. I was looking at the PSW and the nursing home, and I'm still trying to question is that when was last time a whole bunch of PSW have an education on how to do infection control, especially after the COVID-19 has started. And the last, but also very important, personal protective equipment. So I will spend the next 10 minutes on looking at personal protective equipment. And the personal protective equipment has to be appropriate for the situation, and how to care for the personal protective equipment, especially when we now have option of extended use and reusing them. In the last 7 days or so, we got a lot of recommendations. The Public Health Ontario now is recommending use of personal protective equipment for care of individual with suspected or confirmed COVID-19. And in that, it's kind of saying that at the very beginning, when it first started, they recommended like as airborne protection. Now, after 2.5 months, they say that now all the epidemiology data has demonstrated is droplet and contact transmission. And Maureen was just saying that mostly of droplet contact is kind of, we don't know that about at this time. So, but at this time, I think we still need to use both droplet and contact protection. Most of them are person-to-person transmission, and there's no evidence is through the airborne route. And that was actually taken from this particular document. So we have to, well, I definitely am no expert in infectious disease, and I rely on Public Health Ontario and the people who are known to let me know what type of what mode of transmission it is. So we're looking at droplet and contact transmission. And also Ontario Health, I don't know who that is. Suddenly I got this thing now called Ontario Health, and I don't know what organization it is, but I think it's a government organization. I think maybe Ministry of Health. And also have optimization the use of personal protective equipment during the pandemic as of April 11. So if you Google those things, at least the Ontario government, I'm sure the Canadian government and other provincial government have similar guidelines. For droplet transmission, and what we're concerned about is the droplet when a person sneeze, cough, and talk. And now how to stop the droplet? Number one, control the source. So mask the patient. If the patient comes in with have any respiratory symptoms, and now some hospital, it doesn't matter what you're coming in, they put a mask on you because of the asymptomatic shedding of the virus. So mask the patient in the healthcare facility. And obviously, and we'll address it later on, Dr. Tam suggested that we should also maybe think about using face covering, which is not a mask, it's a face covering, any devices that cover your face. The next thing is face shields. And I want to spend a little bit more time on face shield because if you look at droplet, face shield will cover your forehead, your eyes, your face, your nose, and your mouth. And if it is droplet, and mostly droplet, face shield will probably give you the best protection. And I'll go on to a little bit more later on when I talk about face shield. I want to talk about the difference between mask and respirator and the goggles. And I want to also talk about elastomeric respirator. And contact transmission, probably not to go to it too much in here on today's talk. Face shield. As I said, from an engineering perspective, industrial hygiene perspective, it's probably the most effective covering for droplet transmission protection because it stops anything that coming to you that's sent that right on, because all the droplets will fall on the face shield. And because if you're wearing a goggle and a half-face respirator, the droplet will still end it on your skin, and which I kind of didn't think that was so great. It's a lot more comfortable than goggles, and you got to figure out when to use them. There are two types, single use, and the one that integral part of a surgical procedure mask, or the reusable, which now I understand one company actually bought it from Amazon. And I'm looking at no, this particular face shields are actually made by the Western universities. The only advertisement I'm doing. The engineering department made a lot of these things for the healthcare workers. And requirement for face shield is really that's recommended by Health Canada. It's a bit comfortable, but it also covers the face and have been visible. You can see through it. That's for eye and face protection. But there is really, I cannot find any government agency that enforce the use of what type of face shield that you can use. That's why a lot of people in their time are making face shields so that the healthcare worker will be protected. Goggles. Real goggles are very uncomfortable if they put a very good seal between your eyes. This is chemical goggles that are fogged up. And then I went to some hospital, and they said, well, we're using goggles. I look at them, they're glorified safety glasses. So, but they will cover most of the eyes. At this time, I have no difficulty with using safety glasses that have side shields, using as quote unquote, they call them goggles. Gloves. I want to take a minute to talk about gloves. And Maureen and I worked on the latex allergy probably around 10, 15 years ago on gloves. And at that time, we looked at different types of gloves. And not all gloves are created equal. They all have holes. Sterile gloves have less leakage or breach than the procedure gloves. And I didn't put it down here. The number of leakage is probably the least amount of nitrile and then latex and vinyl. And we found out in a glove study way back then, if you start moving your fingers and manipulating things, your gloves start to break down and have leaks. And there are some requirements. Latex glove you have to require by 0.24 millimeter and nitrile is 0.16 millimeter. As I mentioned, gloves are not 100% with no leakage. They do leak and they do break. That's why it's so important to have hand hygiene after glove removal. Masks versus respirator. Strictly, a mask is not a respirator, but that's industrial hygiene talk. The masks are approved by FDA and classified by ASTM, but the respirators are approved by NIOSH. So you're talking about NIOSH terminology. And the mask protect the, originally the surgical mask, procedural mask, is actually protect the surgical field so that the surgeon, when they talk or sneeze, will not contaminate the field. And now mask has morphed into now not only protect the surgical field, but also protect the patient and protect the wearer. The respirator at the beginnings only protecting the wearer, has nothing to do with protecting the surgical field or the people. Medical mask.
Sydney,
Yes.
I just want to let our audience know that if the speakers are willing to stay a bit longer, that would be great, so we could address the questions when you finish with your slides.
Okay.
So are all the speakers okay to stay a bit longer?
Yes, no problem.
Okay, excellent. And for those that are signing off, I have recorded the questions, and so I will we'll get back to you with responses since I have your names other than the anonymous ones. Okay, so Sydney, take a few more minutes then with your slides, and then we'll address all the questions if that's okay.
And then the mask is ASTM, and then somebody looking at half face, that's the elastomatic respirator on the lower left, and on top is the full face mask, and which a full face respirator which you don't need. Filter face mask. N95 originally was industrial operations to protect the wearer. So you can actually buy, I don't know whether you can see this, a NASCAR's N95 respirator in here. And they're different approval, NIOSH, the US approval, but then you have the European, China, and different people approval. And they have different testing methods. Just because a person said, I get approved from country ABC, not necessarily they're good. Medical mask is different from the regular industrial N95 as they have to be splash resistant. Okay, N95 beyond shelf life. Yes, Ministry of Health and said yes, you can use and beyond health for training purposes, for fit testing, and my opinion and most other industrial hygienists' opinions that yep, N95 filter face mask beyond its expiry life is still very good, and as long as you make sure the straps are intact and the little sponge when your nose clip is still doing good, and you can still fit test with it, and that is good as beyond the shelf life. Extended use of N95. Originally, N95s are meant for industry and go up to 8 hours. Now the hospital are recommending people are using for a longer time, and I believe that is workable. But once you take the N95 off your face, I don't think you should put it back on again. That's my personal opinion. I don't care how careful you are, you will contaminate it. Once your N95 is off your face, it should be either sent for recycling or discard. Okay, the contamination of N95s. There are 3 approved methods. Hydrogen peroxide vapor is working pretty well. FDA have an authorized third party to do it in the States. UVC is good, but sometimes it may damage because the ultraviolet light may increase the oxidation of the rubber and may not be as good. Heat and humidity depends on the temperature, and it depends on the relative humidity, and something that you may or may not want to try. Elastomatic half face. Right now, there's quite a bit of debate. It was meant to protect the wearer. Some physician actually went out and bought some elastomatic half face mask for the use in the OR, and I said, no, you cannot do that because at the exhalation valve, it will contaminate your surgical field. Okay, that is, I believe, aerosol generating procedure. That was talking about aerosol generating procedure. But then we cannot forget about dentistry, home care. The home care worker go to home to do suction, moisture oxygenation at home, and funeral home. They do also do aerosol generating procedures. And those are the PPE recommended by Public Health Ontario for different process. And face covering, the last one, is not a respirator, not a mask, not being approved, but it will stop the aerosol from expiring from the area and may stop from aerosol coming to the area. And it's a good deterrent from touching your face. And it also can be used to mask the patient. And duffing and donning, those are 2 good YouTube videos that you can watch. And then my last personal recommendation is you need to prioritize your N95 respirator. The best one is the NIOSH approved medical ones, and then NIOSH approved non-medical one. And any NIOSH approved respirator that's beyond the shelf life, and then you can use other approval medical respirator, and then the extended use and the reuse of the disinfectant N95s. I give you a few useful references and then for questions.
That's great. Thanks so much, Sydney.
You're welcome.
So what I'll do is I will share my screen with the questions here, and any speaker that wishes to speak to those questions can address them. And some were posed early on in the presentation and therefore may have already been answered, so it might be a quick response. So the first question here is around guidelines on what on the medical conditions, and I believe Maureen addressed these. And then, you know, what would be, I guess, how would this translate into restrictions?
Hi, Aaron. I actually also see there was a question just above it, perhaps, about looking at the experience of somebody doing an NPS swab. So that is
yes.
Yeah, it is really important to do it correctly. And they do have some validation so that like when you do the twisting around, and there should be about up to like a million epithelial cells that they will get in terms of a specimen. So it's really important to do it correctly. And an NPS is going to be much better than a throat swab, for example.
Mm. Okay, and I know some of the studies that were looking at the sensitivity specificity of the test were comparing we're using different gold standards, so that would affect the results.
Right.
Sydney, you were just addressing the PPE question, and so the question is whether hoods are better than N95s, and I think you've answered that quite well already in your presentation, particularly around the face shield aspect. Did you have anything further to add to that question?
Yes, I think I saw that some PAPR and compare PAPR with N95. PAPR has the assigned protective factor of 25, and half-face N95 has the assigned protective factor of 10. So PAPR is a better respiratory protection. But we are looking at droplet protection, and yes, PAPR will get you the face shield.
Okay, excellent. This question was around the aerosol transmission, and Alan addressed this quite well, as did Maureen. And so I believe the current understanding is that they're through droplet and aerosol, but not airborne. Anything?
Correct.
Okay. The immunocompromised question comes from rheumatology, and I guess, is this specific to rheumatology patients or not? And I suppose the answer would be that any form of immunocompromise would pose equal risk.
Right, so it's looking, I wouldn't say it's exactly equivalent risk, because I think it does depend on the diagnosis, it depends on the medication, it depends on the immune system. For example, people who've had a stem cell transplant or hollow organ transplant, then those would be considered at the highest risk. In terms of rheumatological patients, and they could be dermatology as well, so people who are on the DMARD sort of class of drugs, then those are probably, if they're requiring it, and if they're flaring, if they're not really well controlled, then that's probably a group that you would like to have, if they can't work virtually, if they need to be in the hospital, then to at least be working in an area where they're not having exposure to patients with COVID. And I do see there's a question there about masking, universal masking in the workplace. And that is something that's being done. I'm not sure across the country how much that's being done, because there's such a wide variation in terms of the epi, but certainly in Ontario and in Southern Ontario, it's being done routinely. And it is that paradigm in terms of looking at, you're wearing the mask at that point for source control. So people often, when they put the mask on, they're putting it on to protect themselves, but in fact, it's the source control. What we also know is that cloth masks are actually pretty lousy. They don't do a very good job. A low quality sort of procedure type mask actually does pretty well. And then if you can contain the droplets, particularly for people early in disease who we know can have high viral loads, it can be very helpful. So that is a fairly common recommendation now if you're in hospital, if you're front facing or in long-term care or in these other places that you're, and even looking into home care, that in fact you would be wearing it.
Excellent.
I had a question too,
about
Aaron.
the cloth. Sorry, Alan?
Yeah, no, I had a question for Sydney about the face shield. If you wear a face shield, how do you avoid getting the respiratory droplets from being inhaled through you're not wearing another, if you wear an N95 and a face shield, is that not the best protection? Because then you're not getting respirable particles less than 5 microns.
Absolutely, Alan, you're absolutely right. Face shield should be used in conjunction with either a surgical mask or N95 underneath.
Okay, that's what I thought.
Yeah.
But a face shield by itself is not total protection.
No.
Okay.
Correct.
That's what.
Okay, the next question, I'm not sure if I understand it. Is there data that indicate that first responders have a higher negative impacts compared to healthcare workers?
I'm not sure that I understand the question either.
Yeah, I'm not, okay. We can move on. Okay, any breakdown on symptom presentation? So I guess that's the relative, you mentioned anosmia is I think it's the most frequent. It's the most frequently reported symptom.
I heard 30%.
Yeah, initially it's fever, cough, new onset cough or worsening cough, and difficulty breathing or shortness of breath. Those were sort of the classic symptoms. And then in addition to that, very commonly now, there does seem to be one of those nasal symptoms. So whether it's nasal stuffiness, runny nose, sneezing, or anosmia, or just juicy, or however you say it, when you lose your sense of taste as well, that those are quite common symptoms. And then below that would be the throat symptoms, and below that would be the GI symptoms.
And Aaron, I would add, just from my limited research from the studies coming out of Italy and Wuhan, is the time from symptom onset to adult respiratory distress, acute respiratory distress syndrome, is median about 8 to 10 days, which is, you know, you can go from, they send patients home with O2 sat monitors, little portable O2 sat monitors, and if their O2 sat goes below 93%, come on back to the emergency room, and they're often usually intubated and then vented for at least 21 to 28 days. And if you're talking about an illness that goes from 0 to ventilation in 8 days, that's a disaster.
Mm-hmm. Yeah, one only needs to look at Boris Johnson's clinical course to illustrate that. Maureen, did obesity come up as a risk factor in any of your?
No, interestingly, it did not. Okay.
Pregnant workers. So Maureen, you answered this already, and the Society for Gynecology and Obstetrics has a clear statement on this, I believe.
Yes.
During swab testing, when the patient coughs, doesn't this generate an exposure potential in the breathing zone of the tester? Why not recommend N95? Is that it's an aerosol is it an aerosol generating procedure, I guess is the question here.
No, it's not. So, I mean, it gets confusing because, of course, aerosols, I mean, we expel aerosols when we're talking, laughing, singing, that probably is one of the highest, sneezing. But what you're doing, it's not going to be, it's not artificially airborne in the way it is if you're doing, like if you're manipulating an airway, doing, say, a difficult intubation, for example. So as long as you've got droplet contact precautions on when you're doing an NPS swab, you should be fine. The other thing is sometimes people will ask the patient to wear a mask while they actually, like, just over their mouth, and they can do the nasal swab.
Okay.
Actually, what they're doing in California is in these mobile COVID assessment centers, they actually give them the NP swab, do it yourself, and then drive down to the next station and hand it over, so that there's no generation of any possibility of generation of aerosols.
Yeah, I'm not sure the false negative on those ones.
Well, who knows? Who knows?
The trained person.
There are some interesting studies actually right now where the screener is doing a swab and then the healthcare worker is doing their own, and they're looking for correlation. So those are studies that are ongoing right now, and they're kind of hopeful as long as they're being given good instruction in terms of how to take their own swab.
Wow, if self-testing is an option that's viable, that's fantastic news.
Yeah. And also all the assessment centers that I've been to, almost all the people who are doing the swab are wearing face shields with the respirator underneath. So I'm not too concerned about them being exposed.
Yeah, and I'd be fine with the surgical mask and a face shield.
Agreed.
Question about temperature checks. I guess I would add to this: is temperature check a useful screening tool? And if so, then what's recommended?
So ideally, if you're going to be doing it, it would be a no-touch temperature check. So there's no point in putting a screener at risk in terms of doing an oral thermometer, for example. It is interesting. We've picked up a number of people who've had fever and nothing else. It's also a challenge, and I remember this back in SARS as well in the winter. So people, they may have a fever in an hour, but when they come in, they're hardly registering because it's cold outside. And if they're so it's not perfect, but it is another screening tool.
Okay. Next question is about immunity. Is there evidence?
There is evidence, and in fact, some of the studies that are being done now around those who've recovered and doing plasmapheresis and getting antibodies, and there have been trials in terms of treatment with antibodies that have been promising.
Regarding negative nasal pharyngeal swabs, should they be repeated? And if so, how long after the initial?
So probably 24 hours, and it depends again in terms of what the index of suspicion is. So if you've got somebody that has been, say, a contact of a case and they don't have any symptoms and they're negative, then I wouldn't redo it until they develop symptoms. But if you've got somebody clinically who's presenting, then it should be repeated again in 24 hours. And you may also do a throat swab at that point. So you would do an NPS and a throat, and then start making sure that you get the chest x-ray done or CT, because you may be looking at a lower tract specimen too for diagnosis.
Excellent. Is there a self-screening app that anyone's aware of?
Yeah, there's one in Ontario. There is a self-screening app. It's under Ministry of Health, and it has, you pull it up and it asks you all the questions. The other thing it also asks is that we're focusing on the healthcare worker, but on the patient side, if you have somebody who has cognitive decline, falls, just change in mentation, then that's also the way that it may present. And those are things that are on that screening app as well.
Yeah, and Aaron, just to add further to that, we've actually put it as part of our communication, the self-screening assessment. So it's really, really quite a useful tool. Now, it picks up a lot more than possibly what you would ask in a face-to-face interview, but we're all doing this remotely, so we put that as part of our employee communication.
And a self-screening app has got good and bad. We have we have company who have essential workers. In the Ontario one, if you have nasal congestion, you have a hoarse voice, you recommend it to self-isolate for 14 days. And we have a lot of people who now called in and said, well, I self-screen positive on a self-screening app. I'm not coming in for work for 14 days.
Yeah, that is the reality of it, unfortunately.
This next question is, I'm just going to jump to the Alan, you mentioned medication. There was a question. Which medication did you mention?
It's called remdesivir. Sorry, REMESDIVIR. Remdesivir, and it's made by Gilead Science. And right now, it's probably the only major antiviral that's being studied, other than favipiravir, which is the Japanese antiviral that was also used for other coronaviruses as well as influenza. But the best part about remdesivir is it does have some usefulness in treating SARS and MERS that you mentioned, and with some good studies to back that up. The question is, does it work for COVID? And so far, the initial studies show that it's been pretty helpful to take people off their vents and return them back to oxygenation.
Great.
I may have spelt it wrong. REMDESIVIR. And they studied severely ill patients. So they gave it to severely ill patients. 68% of them responded.
Could you spell it one more time for me?
REMDESIVIR.
Okay.
There are several randomized controlled trials in Canada as well that are using it.
Excellent.
And there are some antiretrovirals as well, ritonavir, lopinavir, that are like HIV type drugs that are also being in trial.
Okay. What do you think is the best approach given the current situation in terms of healthcare worker surveillance? And you can see there what's been suggested.
I don't know that I can see it in front of me, actually.
Oh, are you seeing my screen? No.
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 Okay. Universal source control, or exposure risk-based screening, or active monitoring for symptoms, or ongoing screening with swabs every 4 to 7 days.
Well, probably the least one would be the ongoing swabs every 4 to 7 days, because it's when you swab, it's really always just a point in time. Ideally, what you'd have is a very low bar or low threshold for symptoms. So there's like about a dozen different symptoms. So if you have any single one of those symptoms, looking to get tested at that point. So I think that's probably going to be your best. But as with many things in infection control, you do them in bundles. So the other thing then would probably be, if you are in healthcare settings and you are front facing, then wearing a mask for source control would also be a benefit.
Great.
Yeah, in the hospital I'm looking after, everybody who walk through the door will have to have an active screening. And if you show any one of those symptoms, then you will be sent to the assessment center and be swabbed and sent home. Because the hospital that I look after has relatively less than 12 hours turnaround time in terms of the testing, and then we got relatively quick answer. I think that's probably a middle of the road, but a very effective way of screening. The only problem right now we're trying to ask one more question is because allergy season is here, and then yes, I have nasal congestions, I have a cough. And then
what we've done, Sydney, is we've put in unexplained, new onset unexplained.
Okay.
And I think you should add also that a lingering cough post-COVID does not necessarily mean that you're still symptomatic. I think that was the other thing that I saw in the Ministry of Health website.
Okay, we have a few tough questions here. If the outbreak is peaking, when should we reopen our occupational health clinics?
Oh, you mean an office, a medical office?
I suppose so. It says our occupational medicine clinics.
Well, from what I've read through the, and by the way, all of you should look at the CIDRAP website. It's out of Minnesota. It's excellent. What I've seen is that we're waiting for 2 incubation periods, which means the first incubation period is 14 days, and then the second one's another 14 days. Once you get past those 2 incubation periods, then the R0 or R0 and goes from, say 2 to 3 individuals being infected to R0 being 1 person being infected if they have the virus. So that's what we're trying to do, besides flatten the curve. To flatten the curve, but you need to wait 2 incubation periods of 14 days each before you can say we're now on the tail end of the peak pandemic phase, and that's critically important to where we're going to be heading.
Which is why we keep hearing 28 days and we'll review.
Right. So it's two incubation periods.
A quick question here is, what is exactly meant by viral shedding? Is that just referring to the contact droplet vector or another route?
Viral shedding is from it can be from the mouth or it can be from the feces. So it's any sort of body secretion where you can have positive virus. So we do know that there's viral shedding, for example, in the stool. That was one of the things. What's difficult to say is that even if you might have positive testing at that point, it could just be still viral particles that are not necessarily virulent.
Right, or viral RNA fragments that have been showed up in Wuhan patients up to 37 days in the stool.
Yeah.
Could one of you address rapid antibody testing? Is it reliable?
Not to my point, no. It hasn't. It's really been kind of a dismal failure. Now, there may be some other information out there that I'm not completely privy to, but.
Maureen, there's another question about comorbidities and lung concerns. What chronic lung diseases are most at risk?
COPD and asthma that's difficult to control.
Okay. Return to work process for healthcare worker who tests positive and wearing surgical mask.
They shouldn't. Anybody who's positive, whether they're symptomatic or asymptomatic, shouldn't be at work. And so then you need to wait one of 2 things. So the gold standard has been that you would have 2 PCR tests at least 24 hours apart that would be negative. The challenge is, as we're finding, is that this often is stretching out even beyond the 14 days. So the other is there is a non-test method. So if at the end of the 14 days and somebody's had at least 1 week of being symptom-free, then it's probably reasonable for them to return to work. I know BC is not using any kind of testing. In Ontario, they still suggest either the test method or non-test. We've been using the test method to date. Most people are going to be cleared by 10 days, but not everybody.
And Erin, it's in the Ontario Ministry Public Health, Ontario Public Health website. They just updated it on April the 10th. And they have a beautiful table for healthcare workers.
Okay, great.
And Alan, it's actually being updated again. So
Again? Okay, I
don't
stand
look at that
corrected.
one.
I'm sorry.
It needs 2 or 3 changes in it, so don't look at that one.
Okay, because the first
That's
one
why
was
I said
March the 12th. Okay.
That's why I said at the beginning, what I'm saying to you now is outdated.
Yeah.
Okay, so this is a pointed question about hypertension. It's so prevalent. If a patient's well controlled, can they work or not?
Yeah, I know it's a difficult one. These are sort of case by case basis, and it's in terms of what you're looking to do. There's no easy answer on that one, and I think it depends on also what they're doing. I mean, ideally, if you've got the ability, what you would say is, you know, continue to do your work with the usual patients that you would see, but ideally that you wouldn't be assigned to a COVID ward.
Okay, there have been a number of questions around masks and reuse of masks. And I know, Sydney, you already addressed this and said that ideally you wouldn't wear a mask again. Here's a question that encompasses all the questions that have been asked around this. In setting up a family practice in Nova Scotia, we're being given 2 surgical masks per week, and have been recommended to reuse the mask unless visibly soiled or wet. Can you comment with respect to risk of contamination?
2 surgical masks per week? Well, it is difficult. Surgical mask is not as rigid as the N95 half-face filter, and they're quite flimsy. It's very difficult to help them to maintain its integrity. So 2 surgical masks a week is, to put it politely, really pushing it. And also, how are you going to store your mask at night? And there was some suggestion using a paper bag because of the moisture. And then you have to use a new paper bag each time, because once you fold your paper bag, the one that is dirty side will touch the one on the clean side. So your your paper bag will now be contaminated. So I don't know what to do with your assigned only 2 surgical masks a week. And you still have to do your job, and I would really truly ask for a lot more. 2 surgical masks a day is probably, I would say, minimum that I would say is something that I can live with, because you have to rehydrate, and once you take your mask off, if you look at the possibility of contamination, it's usually the duffing of the personal protective equipment that you contaminate yourself or things. And surgical masks are quite flimsy. So at least if anything, that I would ask for a more rigid type of mask, or no, and it is a tough thing, and if you can find another way to get your supply of a surgical mask elsewhere, please do so, because I don't think a uncertified surgical mask or mask is better than a surgical mask that is certified but is contaminated. So by all means, try to find another way to protect the droplets from getting to you.
I think one of the things is wearing a face mask is helpful. The other is taking really great care with the mask. They're often like an ear loop mask. There's a recommendation that you would have like a plastic container that if you're taking it off to eat or go to, you know, whatever, to then put it sort of face down into the thing, and when you're pulling it up again, so that way you're trying not to self-contaminate. I know it's a real challenge because there's such a shortage of equipment. It's really, really, really difficult. So unfortunately, trying to preserve and doing the best that you can, but changing out the paper bag at night, as Sydney says, because then you're keeping dust off it, but it's still breathable. You do not want to put it in a Tupperware container or a plastic bag. The other thing is looking at trying to do as much virtual care as you possibly can. And if you're seeing patients in an office, just have them one after the other in terms of doing whatever it is that you need, cleaning your hands in between patients.
Excellent. It's 1:30. I think we should close it off. I know there's a number of other excellent questions that have been posed, but one of the comments was that the individual would be interested in another webinar, which I think is a fantastic suggestion. We probably, in retrospect, could have done this as 3 separate webinars with each of you presenting separately, given the amount of interest and fantastic information that's been provided. I want to thank all 3 of our presenters today for the information they provided, their expertise, and for sharing that expertise. And OMAC and CBOM and OMSOC will look to try and put together another webinar so that we can continue this excellent discussion. And has been pointed out many times, the information is constantly changing. So thanks again to all the speakers and to all the participants for the fantastic questions and your participation. And I'll close things off at this juncture.